So before I begin, I would like to acknowledge the traditional custodians of the lands from which we are all meeting today. I'm joining you from the lands of the Kombumerri people, and I extend my respects to their elders, past, present, and emerging. I'm Dr. Michelle Shahid. I'm your host today for this webinar, which is brought to you through the Prevention Centre's Emerging Leaders Network. This is a network of early to mid-career researchers, policymakers, and practitioners who are working in chronic disease prevention across Australia. And the goal of the network is to cultivate a dynamic and enduring future prevention workforce that has the capability to drive the co-design of applied policy relevant research, as well as translate and mobilize that knowledge for the best policy and practice impact as well. So for those of you who are new to this network and the Prevention Centre, I will invite our head, Nadia Masterson, to give you a brief introduction of the Prevention Centre.
Thank you so much, Michelle. Hi, everyone. It's the first time I'm joining this platform, so I thought I'd take the opportunity to introduce myself. So I joined the Prevention Centre late last year, and as a really passionate advocate of both partnerships and prevention, stepping into this role was really rewarding and a really natural fit for me. So it's fantastic to be here. Just a tiny bit about myself. I've worked in the prevention landscape for over 25 years now across a whole range of different areas. So healthcare, Aboriginal community controlled health services in remote South Australia, non-health sectors, local government, primary healthcare, and most recently a significant amount of time in policy roles within the Department of Health in South Australia. And so I guess I bring a range of experience to the Prevention Centre and really pleased to work with the wide and vast network that we have. For those of you who might be new to the Prevention Centre or new to the Emerging Leaders Network, the Australian Prevention Partnership Centre, or the Partnership Centre as we like to say, are a centre of the Sachs Institute, and we're proudly funded by these policy and practice partners that you can see on the slide here. And I know that some of you attending today are from some of our partners, so welcome and thank you for your generous funding. So the Prevention Centre, our mission is to support an equitable, effective and efficient chronic disease prevention system for Australia. And we do that through three main ways. So the first is around building system leadership, and that's through our incredible networks, communications and capability building approaches. The second is around supporting new knowledge and making sure that that knowledge is co-designed and co-developed with policy practice community members to ensure that we have really useful and effective translation on the ground, which leads on to the third area, which is accelerating the use of that new evidence to inform policy and practice. So staying across really important issues like the one we're going to hear about today are really important opportunities for all of us as researchers, policymakers and practitioners alike. So I'm looking forward to this session. I hope you are too. I'm going to hand back to Michelle.
Thanks, Nadia, for that introduction. Just a brief reminder as well that this session is being recorded and we will be sharing that recording with the members who are joining us today at a later time. Now coming to the focus of today's webinar, this is on the findings of our recently published Economics of Prevention Knowledge Synthesis. Why this was important is because health economic evaluations assess the cost and consequences of policies, programs, and interventions, and they aim to inform decision makers on how to best allocate limited resources, both efficiently and also effectively. So to learn more about the findings from the synthesis, today we are joined by our very honorable guest speaker, Associate Professor Jayatri Ananthapavan. Jayatri leads the Economics of Obesity team within Deakin Health Economics and the Global Center for Preventive Health and Nutrition at Deakin University as well. She is also a member of our Scientific Advisory Committee and has made significant contributions to the area of health economics and chronic disease prevention in both consulting as well as in academia. So thank you so much, Jayatri, for joining us. Welcome, and over to you for the presentation.
Thank you so much, Michelle, for the lovely introduction, and also for the Prevention Centre for organising this webinar. So I'm going to get started just talking about what a Prevention Centre knowledge synthesis is. So it's a little bit different to other types of reviews or systematic reviews or scoping reviews that you might be familiar with. And the objective of the knowledge synthesis is to really synthesize and communicate the policy and practice implications of the prevention research that's been undertaken by the Prevention Centre. And the reason why it's not like a typical review is because it really engages all different aspects of the prevention landscape, as well as, you know, the professionals working in prevention to identify those policy and practice implications. So at the start of the review process, the start is basically coming up with those research questions. And in most knowledge syntheses, this has involved a policy dialogue with policymakers to co-produce those research questions that are really most policy relevant. And then there's a process where content experts look at the evidence and synthesize or try and elicit those key messages from the research that's been produced, and then we engage knowledge translation experts to actually communicate those findings. So on the right side of your screen there, you can see the outputs of the knowledge synthesis for the economics of prevention, and a very pretty report, which has a full report as well as, you know, a synthesis of, or a summary of the knowledge synthesis, so that you get the key messages really quickly. And you can download the knowledge synthesis at the Prevention Centre website. So Prevention Centre, so members of the Prevention Centre have also actually published what they've learned from the knowledge synthesis, and I'd encourage you to go and have a look at this paper as well, just to see what the key findings and, you know, the reflections of this new way of actually synthesizing evidence. So the knowledge synthesis for the economics of prevention was a little bit different, again, from other knowledge syntheses that the Prevention Centre has undertaken. And so that mainly related to the co-production of the research questions. So where we started was that we already had undertaken a economics of prevention policy dialogue with policy partners, and the aim of that dialogue was really to establish what economic evidence policymakers need to make the case for investment in prevention. So that was undertaken in September 2021. And then after we identified those key kind of issues that policy partners were having in terms of making the economic case for investment, we went away and came up with some research projects that could start answering those questions. We then fed that back to the policy partners, and together we came up with a prioritized list of projects that can actually answer these various, that could provide the evidence that these policy partners were saying that they needed to make the case for investment in prevention. There was then funding from the Prevention Centre, so the Governance Authority provided funding for some of these projects, and then the results of these projects have also been fed back to the Prevention Centre policy partners. So because we'd already engaged with policy partners quite extensively about what their needs were in terms of the economics of prevention, we didn't have another another policy dialogue to actually come up with the economics of prevention knowledge synthesis research questions. What we did was we looked at the policy dialogue transcripts and tried to elicit what those policy relevant synthesis questions were. And so here are the knowledge synthesis research questions. So the overall question was, what have we learned from the Prevention Centre Economics Work Program to date? And the sub-questions were around what type of economic evidence has been generated by the Prevention Centre, what types of questions does this research answer, what are the key areas and key findings from this program of work, and what are the implications for research policy and practice. So I always like to take an opportunity to try and talk a little bit more about economics and why it's important. So I'm just going to provide a little bit of a background on economics, why it's important, what the different types of economic evidence are that can be used to inform decision making, and also the key considerations when determining what type of economic evaluation should be undertaken in different contexts. So why is economics important? And the key reason is that all societies, regardless of if we have large budgets or small budgets, have limited resources. And these limited resources contrast to the unlimited needs of society and the wants of society. So what that means is that we need to make choices, and we need to determine how we should invest our limited resources. So economics is the study of how to maximize the societal welfare, or in this case, health, with the available resources. And another reason why economics is really important in the context that we're in is that healthcare costs are continuing to increase, and government decision makers want to know how much the intervention or the policies will cost and what benefits they would expect to receive from that investment. And the purpose of health economic evidence is to assist decision makers weigh up the costs and benefits of different options before deciding on how to invest society's resources. Another context in terms of prevention is that we have a very small proportion of the health budget that is spent on prevention. And so what economic evidence can do is actually tell us how we should use this limited prevention budget to maximize health outcomes. But we also know that we can demonstrate from economic evidence that prevention is really great value for money. So it also provides the evidence to advocate for more investment in prevention. Okay, so moving on to the different types of economic evidence that can inform decision making. So we can describe the different tasks that the economic evidence actually does, and that is basically descriptive studies. So descriptive studies involves estimating the burden of disease or the cost of illness associated with various illnesses and risk factors. So these type of studies can alert decision makers to the high health, social, and economic cost of various diseases and risk factors and alert them to the need for action. Okay, so it can answer questions such as how much does obesity cost the Australian economy every year? Although these studies kind of raise awareness of the need for action, it doesn't actually give decision makers ideas or interventions that they need to actually solve the problem. It just describes the problem. So prediction involves estimating the potential future benefits if you are able to change either the prevalence of a risk factor or illness. So these types of studies can involve economic modelling and can answer questions such as what are the economic benefits if all adults in Victoria achieve the recommended daily physical activity levels. So that also kind of shows decision makers what the potential benefits are. However, these studies don't provide the data on what the best actions are to actually achieve those outcomes. So explanation studies, so they often involve econometric studies which use statistical methods and real-world data to explain associations between economic and health variables. So these studies alert decision makers to the determinants of risk factors and disease. However, no information is provided on the best way to actually impact these determinants. So coming to evaluation. So evaluation provides a comparative assessment of the value for money of an intervention. So a full economic evaluation presents the relative costs and benefits of two or more alternatives. And this can help decision makers weigh up the different choices and provides an assessment of whether a proposed intervention is worth the benefits that it produces. Okay, so it actually provides evidence of whether an intervention is good value for money. So economic evaluations can be undertaken as single interventions or a suite of interventions, and these are called priority setting studies. And the different types of, and there's many different types of study designs for full economic evaluations that I will go into next. Okay, so these are the 5 key types of economic analyses or economic evaluations that can be undertaken. So as you can see, all the different types of analyses uses cost and measured in dollars or whatever currency you have to measure the intervention costs. So the key differences between these types of economic evaluations are how the consequences of the analysis are measured and valued. So in a cost minimization analysis, this type of analysis is appropriate when there's 2 treatments that are identical in terms of the health outcomes that it's able to achieve. This is often the case when you're looking at some drugs which produce the same efficacy. So the decision on whether one drug should be, should be used on top of another comes down to which is the least cost alternative, because all the benefits, the side effects, etc., are identical with the 2 alternatives. Cost effectiveness analysis uses natural units such as BMI reduction or life years gained or blood pressure reduction to estimate the impacts of the intervention. So these type of analyses, so cost effectiveness analysis, is appropriate when both or the 2 or more alternatives that you're trying to compare are all trying to achieve the same thing. So if you're looking at 5 different obesity reduction interventions, then you can use BMI reduction as the outcome measure, because you can then see which is the least cost per reduction in 1 unit of BMI. And then you would rank it based on the least cost alternative. But what it doesn't do is it doesn't allow you to compare an intervention related to physical activity to an intervention that improves nutrition, because the outcome measures are different. We then move to cost utility analysis, which is a measure that incorporates, so the consequences of the intervention are measured in quality adjusted life years or disability adjusted life years as examples. And these are measures that incorporate both the quantity and quality of life of an intervention. So if we say that all health interventions should improve a combination of quality and quantity of life, then we can actually start comparing all types of interventions regardless of what type of diseases or risk factors it's trying to achieve. So these type of evaluations allow you to compare different types of interventions and policies targeting different diseases. And the outcome is an incremental cost effectiveness ratio, quantified as the incremental cost per quality adjusted life year gained or whatever utility measure is used in that analysis. In cost-benefit analysis, all outcomes are monetized. So this proposes quite a few challenges because it's quite difficult sometimes to monetarily value health benefits. But what it also allows is you to incorporate other benefits if you can actually monetize them. So this allows the inclusion of impacts outside the healthcare sector into the benefits calculation of interventions. And the result of the cost benefit analysis is either net monetary benefits or the ratio of benefits to costs. And then cost consequence analysis, what this does is actually lists all the benefits of an intervention without actually going to the next step of measuring and valuing them, so that decision makers have a list of those benefits, but there's no decision rules on which kind of, what combination of those benefits will constitute good value for money, but it does provide a lot of information to decision makers in terms of the costs and the potential benefits of interventions. So the two most commonly used analysis types in the health sector are cost effectiveness analyses and cost utility analyses. But I think it's also important to remember that cost effectiveness analysis, because they're in natural units, there aren't given values. For example, we don't know what the value is of each BMI unit reduction or each life year gained, because we don't know how much decision makers are willing to pay for those. But for cost utility analysis, we know that if the cost per QALY gained is less than $50,000, then that constitutes good value for money. In the same way, if we can do a cost benefit analysis, if we have a positive net monetary benefit, it means that the benefits outweigh the costs and that intervention is good value for money. And if the benefits to cost ratio is greater than 1, then it means that from a societal perspective, that the intervention is good value for money. Okay, there are also some key considerations when determining the most appropriate economic evaluation technique. So firstly, the decision context. So what we need to keep in mind when we're deciding what type of analysis we want to do is we need to decide who the decision maker is, who the audience is for the analysis. And this could be individuals, it could be hospitals, it could be the health department, or it could be cabinet, which involves all different representatives from different departments. And what is the context for the analysis? Is it to decide whether a drug gets put on the PBS, or is it to decide what type of intervention should be part of an obesity prevention strategy? So this then plays into the perspective that's taken in the evaluation. Are we taking a health sector perspective? Are we taking a whole of society perspective? Which then feeds into the type of economic evaluation that is appropriate. And so when you're thinking about that, we want to think about what decision the evaluation is actually informing, who the decision maker is, and whether there's more than one decision maker and whether multiple actual techniques will be useful. So, for example, health interventions may need to be approved by Treasury or go through the cabinet process. And that might require different types of economic analyses compared to cost utility analysis, which is most commonly used in the health sector. The definition of the intervention and comparator are also really important. You want to make sure that the intervention is really policy relevant to the decision-making context. But I think you also want to make, so for example, if there's an intervention that is completely off the table for political reasons, there might not be a reason for actually evaluating it as your primary analysis. But I think there is room to show the value for money of those interventions that are not policy relevant, but demonstrate to policymakers that this is kind of, there are other interventions that you should be considering that might be even better value for money, even though what you're primarily looking at is a really policy relevant intervention. It's also really important to think about the boundaries. So you can never include all the costs and all the benefits of an intervention, because especially in prevention, which has loads of trickle down effects to multiple generations and, you know, different people in the community, etc. So it's really important to be clear about what is included and what's not included in the analysis. The time horizon and the discount rate has a big impact on prevention interventions, because we know that prevention requires long time horizons to actually demonstrate the full benefit. So if we're doing an analysis of obesity prevention in children and we're looking at a 5-year time horizon, you're going to miss all the benefits in terms of chronic disease prevention when they're adults and in middle age. So I think it's really important to consider that when you're looking at designing an economic evaluation, and also understand that the higher the discount rates have a big impact on prevention, and high discount rates really disadvantage prevention. And so then there's a tricky line in terms of if there's Treasury guidelines that require short time horizons and high discount rates. I think it's really important to also to communicate how this impacts prevention and show through additional analyses how lower discount rates and longer time horizons actually change the value for money proposition of these interventions. Okay, so moving on to the methods for the actual knowledge synthesis. So I've just got the research questions there again. So as I said, the overall aim was to understand what we have learned from the Prevention Centre Economics work program to date. And so what this involved was looking at the projects that are funded by the Prevention Centre. And so we had a meeting with Prevention Centre colleagues who have been involved right from the start of the Prevention Centre to identify the projects that were likely to have an economics component. This was then supplemented with a website search using keywords as well as the methodology search on the Prevention Centre website. And in addition, we also looked at the outputs from the Collaboration for Enhanced Research Impact Centres of Research Excellence. So we looked at the CRE websites, and some of these CREs were kind of still just starting out, and many of the economics kind of outputs are often towards the end of projects. And so when the website didn't have a lot of the outputs, what we did is we did interviews with the SERI CRE economics leads to try and understand what was planned in terms of the economics outputs. And then on the right hand side, I've got the data that was extracted from the different studies and reports that we found. So we looked at the type of economic evidence, the study design, the research questions, the key findings, and tried to find what the key implications were for policy, practice, and research. So at the end of gaining the knowledge, extracting all the data, we did have a policy dialogue with policy partners, and we presented the findings. And the aim was really to gain insights on implications of the key findings for policy, practice, and research. Okay, so moving on to the results. So we've been really lucky that building the economic case for prevention has been a focus of the Prevention Centre's work since it was established in 2013. So many of the projects did at least say that they wanted to include some economics work. So of the 25 projects that were identified by of the Prevention Centre projects, I reviewed them and found that 20 of them had some relevant findings for this knowledge synthesis. So I reviewed 79 documents and found that 42 of them had findings that were related to this knowledge synthesis and the key questions. So here are the different areas of prevention that the 42 studies related to. So 26 documents reported economic evidence relevant to all areas of prevention. So these documents investigated things like resource allocation methods, requirements, and the use of economic evidence in decision-making at the community and state level. It looked at how much is currently spent on prevention, and the burden of disease of preventable illness. There were also studies looking at economic evaluation guidelines. So when looking at single risk factors, overweight and obesity had 7 studies, and only 1 study was addressed alcohol as a risk factor. And this really aligns with our findings from our previous policy partner discussions, where economic evidence to support interventions to reduce alcohol harms was highlighted as a key evidence gap and research priority. And since then, there's been additional funding from the Prevention Centre to actually establish the cost effectiveness of alcohol harm reduction strategies. So now looking at the types of economic evidence that were produced. So we had 9 descriptive studies, 5 predictive studies, 3 that tried to explain relationships, and 8 evaluation studies. And the largest group was methodological studies. And this is really quite appropriate for the Prevention Centre because the outcomes of methods kind of studies are relevant to all policy partners and everyone across the prevention landscape in Australia, rather than looking at very state-specific evaluations for specific programs. And only 20% of the studies actually evaluated the value for money of preventive health interventions. So looking at these studies in a little bit more detail. So here I've got the research questions and the key findings from these different studies. So when we're looking at the descriptive studies, the key questions they ask are things like how much is spent on prevention, and the answer is very little, unfortunately. Less than 2% of health spending is spent on prevention. So what is the health burden of preventive disease in Australia? And also, not surprisingly, it was found that the health and economic burden is huge. 1/3 of disease burden is preventable in Australia. And although there have been various different methods that have been used to estimate the cost of preventable disease, they all come up with very significant values. And I think a key finding is that all these studies really did find that the majority of costs are related to productivity impacts of preventable disease. There were studies that looked at the co-benefits of prevention, and one of the key findings is that although this has been investigated quite a lot, there's little reporting of the quantified non-health co-benefits of prevention, and you need those quantifications to actually incorporate them into economic analyses. And there was also a study on how the health system can support or limit chronic disease prevention. And a key finding there was really that it needs to be incentivized, the actual that the health system funding really needs to incentivize prevention practices within the actual health sector. So these are just some findings. I would encourage you to go to the report because each of the studies obviously had lots of different key findings. So I've just got, one-liners here, but yes, there's many others that you could look at. So predictive studies, I've just pulled out the example of the Go Health simulation model, and the key research questions for this study was that what are the health benefits and economic value of prevention of chronic disease to individuals and the health system and productivity, And can a systems dynamic model simulate the cost effectiveness of prevention interventions alone and in combination? And the key findings from these studies was that modeling several risk factors is complex, and that there really was a lack of data to be able to actually develop a reliable tool. So I think this shows that the scope was really large in this project. It was really ambitious. It was well funded, but it was too complex to model, and it lacked the data that was required to actually model all those risk factors at the same time, and the way they actually compound and overlap with each other. So with the evaluations, there were several cost effectiveness analyses related to different areas, and also some partial economic analyses. So the key findings here are that a lot of the interventions that were evaluated used cost effectiveness analyses, which kind of limit how whether you limit the interpretation of whether they're actually good value for money or not. But the two studies that undertook cost utility analysis and cost benefit analyses showed that these interventions were highly cost effective. And the partial analyses really demonstrated that there were ones related to urban planning, where they looked at the benefits of urban planning and found that walkable neighborhoods are associated with health and economic benefits, but it also demonstrated that it's really difficult to measure the cost of actually implementing these changes to the urban and to the built environment, because they are so context specific. And then there was an analysis of liquor licenses, which found that new liquor licenses pose a significant cost associated with alcohol harms in local communities. Okay, so moving on to the methodological studies. So there were several studies looking at funding mechanisms, and a key finding was that in addition to traditional resources such as budget, you need to also think of those other soft infrastructures such as trust, which is required in the prevention system. Studies looking at economics and scalability instruments concluded that economic evidence on the cost effectiveness of interventions is a really key consideration for scalability tools. However, this data is really limited when they try to actually implement it. Key considerations for commissioning economic evaluations. The key findings were that that economic analyses really need to start transitioning to emphasize cost consequence analysis and cost benefit analysis, where the additional benefits of prevention can start to be included in the economic analysis, and that economic analyses really need to consider the context of the intervention and start to measure the short, medium, and long-term impacts of these interventions. The studies that looked at decision-making processes and the use of economic evidence in decision-making, key findings were that the barriers to investment in prevention include things like ideology. So, the notion of whether things are individual responsibility, etc. These kind of played into decision-making processes. And also in terms of trying to communicate that you're intervening now, spending money now, but the outcomes are delayed into the future. So these were seen as barriers to the investment and investment in prevention. And the study also found that economic evidence was often used for advocacy, so to kind of demonstrate the benefits and demonstrate the value for money, rather than used to actually inform what kind of interventions should be invested in. So there were a couple of studies looking at cost-benefit analysis, and that included monetizing health as well as frameworks for using cost-benefit analysis in prevention. And key findings was there's really limited evidence in Australian valuations of value of a statistical life, which is what's kind of required to try and put a monetary value on health outcomes. And there was also a finding that there needs to be alignment of cost-benefit analyses frameworks from across different government departments. The studies that looked at behavioural economics in prevention really concluded that we really need more evidence or more research on the types of incentive designs that are best placed for public health programs. And there's also a study looking at health-related quality of life instruments in Indigenous populations. And the key conclusions was that many of these instruments aren't valid in Indigenous populations, and there are key domains in these surveys that need to be strengthened, including social and community and culture, diet and land use domains that were found to be not really appropriate for Indigenous populations. So in terms of the CERI CREs, I've just listed the actual CREs that have some economics of prevention findings and then the ones that have planned outputs. So I encourage you to go and have a look at the different websites from the different CREs. And have a look at the knowledge synthesis report as well, which has identified the aims and the key research questions and the outputs from each of these CREs. Just to note that one CRE, the Health in Preconception and Pregnancy CRE, is not included on this list because the outputs were actually incorporated into the Prevention Centre outputs that have already been synthesised. Okay, so moving on to the key findings. So the first key finding is that preventive health interventions are likely good value for money, but more full economic evaluations are required. So we know that there's been quite a few descriptive studies that have demonstrated the burden of disease associated with preventive disease. And the key findings are that productivity impacts outweigh other impacts of preventive health interventions. And there've been relatively few full economic evaluations, but the full economic evaluations have shown that interventions are good value for money. And future economic evaluations should consider the non-health sector audiences. So try to consider the co-benefits of prevention interventions and impacts on other departments to try and demonstrate the broad impacts of prevention and also show how interventions can increase sustainability of the health sector. And this was a quote from a policy partner at the Policy Dialogue who said, "We've done enough describing. We need to speak loudly about the descriptions related to the burden and cost of preventive illness that have already been done and actually argue for more evaluation." So we know that, preventive disease costs a lot of money, is a huge burden. We probably don't need to invest more money in those type of studies. We just need to be able to speak to them and use them to demonstrate the need for action, and then actually invest more in evaluation so that can inform which actions should be taken. Okay, so implications from this key finding for research is that the evaluations really need to consider the audience, productivity impacts, equity impacts, and cost sectoral impacts and try and incorporate them into the analyses. We need to continue a research program into funding models for prevention, measuring and valuing short, medium, and long-term outcomes, and also think about how we can actually model these short-term outcomes into long-term outcomes, which then make more sense to policymakers and you can actually make a determination of value for money. Implications for policy and practice is that we need to start commissioning should focus more on the full economic evaluation. You need to increase capacity within health departments to understand, commission, undertake economic analysis. And there were also findings related to siloed decision-making structures, which are barriers to effective co-developed cross-sectoral preventive strategies. And, you know, how we can actually try and work around those barriers to actually implement effective cross-sectoral prevention interventions. And another implication is to continue to communicate the benefits of investment in prevention to the actual healthcare sector. So the second finding is that integrating economics into dynamic simulation models is challenging. And key findings here were that although economics was really considered and wanted to be, you know, all the researchers wanted to include economics, when it was included as a later inclusion into the model development, it was very difficult to actually do that and actually produce results. We know from that every additional component of a system dynamic model adds complexity. So the scope of the studies really need to be considered and thought through, and make sure that there's enough time, expertise, and resources to actually complete that scope of work. The GoHealth tool was an example of a very well-resourced project with health economics expertise right from the start, integrated into the multidisciplinary team. But the scope of evaluating those multiple risk factors was too large and didn't have the data required to actually inform the model. And the policy partners highlighted that these models are really important, but that they can become outdated quite quickly. And so they need to be implemented in a way that can be updated easily. So implications for research is, I mean, I think I've said this. We know that system dynamics modeling requires interdisciplinary effort, and health economics expertise should be included from the start of the project with adequate funding, and the scope really needs to be thought through. And the implications for policy and practice is, I mean, all the Prevention Centre projects have included policymakers consistently, and they would have been an integral part of the model development process. And it is actually critical to get their input in terms of the outputs that are really policy relevant to them, so that they actually are included in determining the scope of the project. Okay, we're nearly up to key finding 3. We've got 4 key findings, and then we can zip through the rest so that we've got enough time for questions. So key finding 3 was that the data to inform economic evaluations is really limited. So many studies reported that the lack of data was a key limitation in their findings. And these limitations include estimates of funding for prevention. They're kind of roundabout estimates because there's not good data to actually estimate that accurately. There were findings that data linkage needs to be quicker and cheaper so that they can be used more effectively in economic evaluations. Costing of programs are often not done when they're actually implemented. Costing methods for urban planning policies are also lacking. And also when programs are implemented, really thinking through the short, medium, and long-term outcomes that can be collected alongside program implementation. And the policy partners reported that, program evaluation has really become standard practice when actually implementing any programs of the health department, and that now there needs to be a move towards economic evaluations being incorporated as standard practice when we're looking at evaluating programs. And they also reported that there's limited information and data to inform cross-sectoral impacts of their interventions. So implications is really to include economic evaluation as a routine component of program evaluation and to advocate for increased availability. So increased data collection of the relevant outcomes for economic analysis and also linkage of routinely collected data. Okay, final key finding is that there are limits in terms of health economics capacity. So there's a limited health economics workforce that works in prevention. There's also limited skills in long-term epidemiological and economic modeling that's required to actually demonstrate the value of prevention. And there's a lack of capacity in health economics within health departments. So, I mean, I think all sectors need to try and, increase capacity of understanding economic evidence and actually producing the economic evidence that's relevant to decision making. Okay, I will zip through these really quickly. So we know that the burden of preventable disease, we also know that the majority of preventable health interventions represent good value for money. So we have to, so there's adequate evidence now to advocate for increased investment in prevention, but more evidence is required on funding models for prevention and the best value for money interventions for prevention. When producing economic evidence, we need to constantly think about the decision maker and the audience to ensure that the evidence meets everyone's needs. This may require using more than one economic analysis technique. Economic evaluations should be included as routine components of program evaluations. So we need to keep advocating for better data collection that can be useful for economic analysis and increased availability of linkage and routinely collected data. Methodological developments for economic evaluation should include taking a broader perspective, incorporating equity impacts and also cross-sectoral impacts. Government departments need to build capacity in the use of economic evidence and need processes to include economic evidence in decision making. And we know that even with the best evidence of the co-benefits of prevention, even if we have those, we need to find ways to work around the siloed decision-making structures to actually implement cross-sectoral preventive health strategies. Okay, so we've got to the end and we've got a little bit of time still for questions. So I really welcome any questions or reflections on what we've found in this knowledge synthesis. So I might stop sharing and open up for questions. Have I stopped sharing?
Yes, Gayatri, thank you so much. That was such a brilliant presentation and a lot to cover. And it was really good to have that context of Health Economics 101 and then the details of the knowledge synthesis, particularly in terms of building that case for investment in prevention. As Gayatri said, please feel free to ask any questions that you may have for her. You can use the chat functions, and also you would be able to access your cameras and your microphones now if you feel inclined to jump on there and ask away. All right. So while we wait for the questions to get going, Gayatri, I was wondering, one of the key messages that the knowledge synthesis really had was that there are large health and economic costs of inaction, particularly on preventive risk factors. So I was just wondering where you think Australia is in terms of tackling that and what can be done better to improve the current situation.
So, yeah, I mean, the knowledge synthesis found that there have been a lot of commission studies. There's been a lot of evidence generated on the health and economic impacts of preventable disease. And so I think we have a very good understanding that this is a big problem. And so I think what we need to do now is actually just take action. So we've got enough evidence to start taking action. We need to invest in more evaluations to actually inform decisions on how we need to take action rather than continue to kind of describe the problem. I think everyone's kind of aware that it's like a really big problem. We just need to start generating the evidence to help decision makers actually take the actions that are required to start making a difference.
I can see there's a question from Amanda Watson in the chat. Amanda, would you like to turn on your microphone and ask that question? If you're still online.
Yes. Can you hear me?
Yes.
Oh, good. I think in all my training through the years, the research continues to show a lack of funding for prevention, and I'm currently working in the health system. So I just wanted to know what does incentivise consist of and over what time period, and what industries would that impact upon?
I mean, I think it's continuing to show that prevention actually has positive impacts on the health system, right? So, healthcare sector is struggling and under lots of pressure. And I think it feels like, people are going to be forced to invest more in prevention because the health system can't actually cater for all the chronic disease that's kind of coming about and will come about in the future. So, I mean, I don't know exactly what those incentives will look like. Maybe someone else who's got experience in the health sector could actually talk about what kind of incentives could actually get people thinking about prevention in the actual healthcare sector. I would value your input, Amanda. What if you had opinions on that?
Sorry, just turning on my mic again. I guess I'm sort of thinking about cross-sectoral collaboration and how important that is. But I'm sort of a health promotion officer working on the ground, so I'm not in research and all that sort of area. So, but I think, as you said with the urban planning, that would be really great if we could start doing more of that rather than just building up houses out in the bush and there's no social determinant aspects in there, so they can't get transport, etc. Environmental impacts, adaptations for disasters would be really good as well, seeing I'm in the north. But how to actually incentivise that, I do not know.
I think maybe a start is actually measuring, valuing, and trying to incorporate them into analyses. So you could actually demonstrate to different decision makers that there's a value in terms of the outcomes that they're interested in actually investing in prevention. So trying to incorporate the environmental impact, looking at the things that the transport sector are concerned about, things like, travel time, all those type of things. If you try and capture all of those type of impacts into the economic analysis, maybe you can start to convince people that, or other sectors, that investment in prevention is a good idea. I mean, I think there's like structural things that need to change, like, we need legislation that requires you to think about health when you're looking at all other kind of policies. So it's probably outside, our level of control, but, there's obviously lots that need to happen for, all sectors to think about health when they're looking at, their interventions and their impact on health.
Thank you. I agree totally.
Thanks, Amanda and Gayatri. I am conscious of time, so just we'll continue the question and answers for those who want to stay online. But I also want to get your attention towards a survey that we're conducting through the Emerging Leaders Network. So this has been designed with the aim to really understand the needs of our membership for future events and activities that will be delivered through this network. And we would really appreciate your feedback. So if you could just spare 5 minutes of your time and click onto the link that's been shared by Karen in the chat and answer those questions before you sign off for today. So yeah, after that, I'll go to Anne. I can see that your hand is up. Yes.
Yeah.
So
hi, Jayatri. Yeah. Thanks for the presentation. It's really useful. So my question is, you say we should increase the cross-sector, economic evaluation. So New South Wales Treasury, their test is a cost-benefit analysis, when in health we have cost-effectiveness analysis or cost-utility analysis. So I just wondering the view in terms of how to talk in the same language. Should we encourage, health economists, how to do CBA so that we can talk to New South Wales Treasury or other sectors better? Or should we just keep doing what we get used to, like a CEI or CUI? And what's your view about New South Wales Treasury just produce rapid to cost benefit analysis? Do you think it could be applied in the health sector?
I know that Treasury has developed new tools. I haven't had a look at them yet, so I'm not sure how they could be used in the health sector. But I think, Anne, you make a really good point. And I think the point I made in the presentation was that these economic analyses really have lots of different audiences. And so I think we need to think about using more than one economic evaluation tool, because you're trying to communicate both to a health audience as well as Treasury. And I think what we need to do is think about, how we can communicate to Treasury, and that there is a paper on the Prevention Centre website about developing a cost-benefit analysis framework for prevention that tries to look at all the different guidelines for CBAs while taking into consideration kind of like the special features of prevention, to kind of demonstrate that CBAs can be done for prevention, how they can be done, and how it can actually be done together with a cost utility analysis. So we are actually talking to many different audiences.
Thank you, Jayatri, and thanks, Anne, for the question. So that's all the time that we have today, unfortunately. In the end, I would like to really thank you, Jayatri, for your time today and for this fabulous presentation, which has given us lots of valuable insights, and I think definitely a lot of food for thought for everyone who's joined today. And we really look forward to seeing all the work that you'll be doing in this space to make the progress that we all need desperately.
Thank you.
I also want to bring the audience's thank you, Jayatri. I want to bring the audience's attention to the fact that we are also partnered with the very capable decision analytics team over at the Sachs Institute for our next knowledge synthesis, which is going to be on dynamic simulation modeling. So do look out for all the new learnings that we will have in that space coming out soon. And I'd also like to thank all the audience for their attention and for the attendance today. You can continue to be engaged with the Emerging Leaders Network through our future webinars, and as well as the different resources that we have on our website if you want to learn more about the topic that we were presenting today, as well as that knowledge synthesis. All can be found on our website. And you can also join us and be part of communities of practice on qualitative research, public health law, and citizen science. And if you have any colleagues or friends who would like to join, please do ask them to head over to the Prevention Centre website or get in touch directly with one of our team members. And that's all for today. We will see you next time. And in the meantime, have a lovely day, everyone. Thank you.